Welcome, and thanks for listening to this week's episode of
The Milk Production.
The Milk Production.
Thanks for joining today. As you can see, the format's going to be a little bit different. My handsome co-host, who is normally with us, is not here today. He is in the great state of Texas, doing his sales job and providing for our family. So thanks to him, but sadly we will miss him. He's certainly the one that brings levity and humor to the event. But because he's gone, I'm thinking that we will try something a little bit different today. And in brainstorming with said co-host, we came up with what we think will be a good name for it, called the TaTa teachings. And we are hoping from that I can sort of do some straightforward education on breastfeeding. So today's episode is going to be geared toward the pregnant mom who is expecting. Anywhere in that journey, it doesn't really matter how far along you are. If you're beginning to wonder about breastfeeding, thinking about it, you've heard some things, you're not really sure, or you're absolutely convinced you want to do it, and you just want to get some nitty-gritty information, this is a great place to start. Now, this is going to be high level, so this isn't the kind of thing where you get deep dive information to any of these subjects. And, I wouldn't have started a podcast if I didn't feel like each of the things that we talk about today is actually deserving of its very own dedicated session. And I'm sure along the way we'll be hitting these topics in more detail. However, this is really the fit it into a podcast, high-level information thing, so it can give you some information to further explore, to learn more about, or to know where you want to ask questions. As an aside, I and other lactation consultants, maybe if you're listening from not near me or if virtual support isn't really what you look for, but myself and other lactation consultants across the country do prenatal visits. And so if you feel like this has really piqued your interest and you want more information tailored to your specific situation or answering your specific questions, there are many, many ways to do that. You can go through something called the Lactation Network to get your insurance to cover it. If you have some of the big ones like Blue Cross Blue Shield, United Healthcare, although I don't think they're covering virtual visits right now through the Lactation Network. Trying to think of some others. I think Cigna sometimes works with the Lactation Network. The bottom line is you should always try. If you have a multi-plan logo on your insurance card, that's another group of people. So the insurance companies may not be ones that I've named, but if you have a multi-plan logo on your card, then that is an indication that you are likely accepted by the Lactation Network. And in doing so, you basically are able to be paired with a lactation consultant with no out-of-pocket cost for the duration of your breastfeeding journey to get all of the lactation support that you need. And that starts now. Even if you haven't had your baby yet, if you have questions, you can get answers, and you will have, again, zero out-of-pocket costs, no copay. The Lactation Network pays the lactation consultant directly, and so you don't ever have to have conversations about money. And further, the lactation consultant never has to worry about saying, hey, I think you need another appointment, but there's that concern of whether the cost is of concern, or whether we're asking too much of the family, or whether we think the family might be perceiving it as, us trying to get additional money. Sometimes you just need that extra support, and it can be difficult to find ways to afford it. But when your insurance covers it, that's really the best way to go. Of course, there are other resources you can use, and sort of just hitting those at a high level before we get started on the education piece would be, you have inpatient support, which is postpartum, right after the hospital, or if you're delivering at home, likely your midwife and your doula will have some lactation support that they can provide. There's outpatient support. So once you've been discharged from the hospital, you go home, you're not loving it, you want to follow up and do a weight check, that kind of thing. Some of these outpatient facilities do take insurance, others don't. do inquire about that before you end up there and hoping to get the information that you need, but the cost is prohibitive. And you can get, as I've alluded to, in-home support. In-home support is the same way in that some lactation consultants accept insurance directly, so they're credentialed directly with the insurance companies, and you can just ask them if they are and see if they take your insurance. Others, and this is becoming increasingly popular, and like I said, just a great setup for both the lactation consultants and the families, is you can go through the lactation network. And even if I haven't, again, listed your insurance here, I recommend going through that. If you're interested in working with me, you can go to my website, locolactation.com, LOCO lactation.com, and I will have a link to, accepting some insurances, and then you put in your information, and that way we would be directly paired. Or if I'm not near you and you definitely want to see someone in person, or you have United Health and can't do virtual visits and you're far away, you can go through the lactation network without being paired with me, and just be paired with a lactation consultant in your local area. Again, covered by insurance, no out-of-pocket costs, no copays, etc. And so with that being said, I think that's also sometimes you have the option of seeking lactation support in like a pediatric office, or maybe even your OB's office. I see it much more commonly in pediatric offices. That is a great choice, especially if you are looking to get it in tandem with another visit. So you've got a well baby visit or a weight check shortly after baby's born or something like that, and you've got a lactation consultant with your pediatric group. Great place to get help. The limiting factor there being that you will have a copay. So again, if you have the option of not doing the copay, then something to consider. Or if you need the support in your home and you just don't want to worry about having to sit in an office that's not necessarily set up for breastfeeding, then again, getting that in-home support is widely available. Of note, Aetna is not in network with the lactation network, and they do credential IBCLCs. And you would need to, this is the case with other insurances as well, but Aetna comes to mind because it's a pretty big one. You would need to call them for a list of providers in your area, or do some internet research and see if the lactation consultant you want to work with is covered by Aetna. Lots of ways to get the help you need, and I'm happy to help provide more information even if you were not working together or something like that. So please let me know if you have questions. So switching gears a little bit, again, to the more tactical side of preparing to breastfeed and sort of answering those questions about whether this is something you want to do. I have pulled together information from a resource that I absolutely love. It's called Carolina Global Breastfeeding Institute, and wonderful research around lactation and breastfeeding support comes out of that institute, and they produce a lot of resources for both parents and practitioners like myself who want to share information more widely and make sure everybody's getting good quality information. And they've created this program called Ready, Set, Baby. And the idea is to sort of educate everyone about the basics that you need to know before you find yourself having that baby and wondering, oh my gosh, I'm in charge of keeping a human alive. How do I do that? So it gives you a lot of good information about having a good strong start. And so we're going to cover that today. And a good starting point is about how to stay healthy during your pregnancy and beyond. So the important things you want to keep in mind while you're pregnant are, there are specific things that you can't eat while you're pregnant. So high mercury fish, for example. So think tilefish, shark, swordfish, king mackerel, and limited amounts for sure of albacore or solid white tuna. Some other options from a fish perspective that are safe in terms of smaller amounts, but normal amounts for what we typically eat, 8 to 12 ounces a week. You can do salmon, trout, sardines, anchovies, and herring very comfortably. So while you're pregnant, obviously, if you have any risk while you're pregnant, if you have any risk factors during the pregnancy, maybe you find yourself working with a maternal fetal medicine specialist or something like that, be sure that you check in with them about how they would like to best manage your diet during pregnancy. But on the whole, provided you don't have any risk factors like gestational diabetes or, high blood pressure or something like that, your typical guidance of eating a healthy, well-rounded meal is where we want to, is what we recommend. You can continue to exercise if your provider says that it's okay, and that can help a lot during labor and preparing you for labor and delivery. So there's no contraindication to that for the general pregnancy without risk factors. Again, running all of this through your provider, OBGYN, maternal fetal medicine specialist, whatever the case may be. Avoid deli meats. I'm sure you've heard that. I'm sure you've been doing that. Soft cheeses. There's a bacteria that can be present on those called listeria. It can also be on the outside of some fruits and vegetables. So be sure that you're washing those fruits and vegetables before eating them. And don't eat anything raw. So sushi or undercooked meats, eggs, fish, that kind of thing. So that sort of wraps up the, how to stay healthy during your pregnancy and preparation for having baby. And certainly as deep as I would want to go because, it's really my area. But do remember also to take a daily prenatal vitamin with iron and folic acid in combination with continuing to eat healthy. Oh, and another thing to remember is during pregnancy, especially during that third trimester, you do need extra calories. So don't be surprised that you're hungry. You need 300 extra calories per day to grow that baby. So monitor that. Obviously, continue to work with your providers if they have more specific information for you on caloric intake or how to manage gestational diabetes if you have it, that kind of thing. So switching gears a little bit, getting to the infant feeding part, the Carolina Global Breastfeeding Institute sort of provides this information and sets it up like a class. So think we're engaging, we're sort of talking together, and I like the model of it because, the next question is, what have you heard about infant feeding? So we'll sort of pause there for a minute as you're chewing on that. Your input might come from different generations. So your mom, your grandmother, maybe your sister. I mean, I know personally for me, basically everything I learned, my entire interest, my ideas about breastfeeding came from my sister because she was 6 months ahead of me with my first, 4 months ahead of me with my second and her second. And so familial input is a very big point where we get information from, as is the information that our friends share with us or, the insight that they provide to us about their journey. Sometimes that's a lot. Sometimes that's a little. Sometimes you see really hard things. Sometimes you see it look miraculous, and then you get to a point of hardship and you're wondering, why isn't this coming so easily for me? So lots to explore there about what you've personally heard about infant feeding, and some higher things to touch on, just to sort of debunk anything that you may have heard differently, is that the majority of infants do receive human milk. So 83% of all infants in the U.S. start out receiving human milk. It is the norm in the United States. Breastfeeding should not be painful. And so what does that mean? Maybe there's discomfort. I used to get this question a lot in the postpartum setting in the hospital. Is this normal, the pain that I'm feeling? And I think it's important to think of pain as an indicator of something going on. So if it's a 2 to 3 out of 10 on a pain scale, so I'm noticing it. I'm feeling this change. I'm feeling the stretching of my nipple, or the dryness or the, that kind of sensation. I mean, those are all new and different. And there is some maybe discomfort in the beginning in the early days, even for moms who have previously breastfed. So that is common. What is not normal or common is when you have, that baby latches and you're at a 7 out of 10 on the pain scale. And remember, you're a mom who's just given birth. So and I get that all the time, like, oh yeah, this is a 7 out of 10 on the pain scale. Coming right off of giving birth, if you're giving me numbers like that about breastfeeding, definitely something's going on. So that's good to be aware of. If it's painful, seek that support either from a provider or lactation consultant or something like that. So another thing to think about, or that you might be wondering about, is like your personal anatomy. Does your personal anatomy make a difference? Or does my breast size matter? Does my nipple shape matter? And largely speaking, no. However, there are situations where it impacts breastfeeding. But keep in mind that your breasts, your nipple, those are the only ones your baby's ever known latching onto. So sometimes do we need things like a nipple shield if your nipple's particularly short or inverted? Maybe. Or if baby's got a tongue tie and it's not going to be resolved for a little while, or maybe it's not going to be revised at all and you're trying to sort of navigate that. Yeah, absolutely. There are oral anomalies and breast anomalies that can sort of impact the normal latch and flow of things. That being said, on the whole, what you've got and what baby's got will typically, be able to come together, even if we have to find some sort of workarounds or additional solutions to continue to support breastfeeding. Of note, a woman with small breasts does not have any more difficulty keeping her baby nourished than a woman with large breasts. So, that's certainly not a factor here. Something else to keep in mind, and you might be sort of sensing this theme already, is that there are things that come up with nursing. So it's not always going to be easy at first. If it was, then I wouldn't have a job. The visual that comes to mind that I always use for moms is, we have this idea in our heads that, oh, I'm just going to breastfeed and this is natural. And shortly after birth, I'm out in a field of sunflowers with my hair blowing in the breeze and my baby's latched and it's all easy and comfortable. And wow, look at me in my postpartum world with my newborn. It doesn't always feel like that in the beginning, especially when you face some of these hurdles that you need to work through. So just give yourself that grace and patience that this requires, and always reach out for that support early and often. That's the best advice I can give you, is reach out for breastfeeding support early and often. And there are free resources, which we can talk about in a little bit. But if, for example, some of the things that I've mentioned before about resources and ways to get that support don't land for you, or for some reason, your situation doesn't support, just know that there are free resources available that can help you navigate some of these tougher times. Another thing to keep in mind is, babies feed at night. A biological norm is that babies feed every 3 hours, and that can happen well into the first year. So what does that mean for you? That sometimes, before having the baby, it can almost seem inconceivable that you're just going to be around the clock feeding every 3 hours. And that can feel overwhelming and daunting. But remember, even if they're bottle feeding, they're going to be needing to feed every 3 hours. When does that change? When baby regains birth weight, provided that happens in a reasonable amount of time, what we tend to think of around the 2-week mark, you can then allow baby to sleep through the night. If it takes, and by the way, sleeping through the night usually means 5 hours. So a 5-hour stretch might be the longest stretch you get, and then 3 hours thereafter. Some babies go for much longer. Some babies continue to feed every 3 hours around the clock and do that for well into the first year. So, remember that they're growing rapidly and they need that frequent, easily digested meal that the breastfeeding provides. Also remember that your breast milk is just this amazing, living, active component providing an immense number of benefits for your baby, some of which we've already talked about in other podcasts, but, kickstarting the immune system, providing antibodies, and the composition of the milk changes over time, even from, the morning into the evening, and from, the first couple days to year one, right? So the composition of the milk is changing all the time based on what baby needs. And that's always a fascinating topic for me, and certainly something we're going to be spending plenty of time on throughout the podcast. Now, all of this being said, do keep in mind that there are instances where medical reasons can make supply difficult, or someone may not be able to breastfeed. The majority of people are able to successfully breastfeed, but what does that mean? We don't have a lot of statistics on low supply and what the true numbers are, or even a really good hold on all of the factors that can impact supply or lead to low supply. And obviously, because we don't understand all of those factors, it's hard to say what the numbers are around who can't, or even why sometimes they can't. There are definitely things worth exploring. If you find you're having difficulties with breastfeeding in terms of supply, hormones, if you have a history of PCOS, polycystic ovarian syndrome, thyroid issues, other things like that. So certainly worth exploring if you feel you have a low supply. It's not the end of the road for your breastfeeding journey. Certainly worth exploring with a provider, a lactation consultant, something like that, or breastfeeding medicine specialist. However, there are other instances where it's just not possible. In certain cases, like for example, if mom has HIV, that's not necessarily well tolerated or well controlled with medications. That would be a contraindication for breastfeeding. There are certain medications, few and far between, that are a contraindication for breastfeeding, and I don't recommend pumping and dumping on the whole. Just, from an ideological perspective, I would like the pump and dump thing to sort of be gone. So if you find yourself in a situation where you're wondering if whether your milk is safe, pump, save it, figure out later if it's safe. Just don't feed it to baby yet. If you need to dump, obviously, okay, that might be the answer, but it's very rarely the case. And if you would like to do some research, particularly as pertains to medications and breastfeeding, LactMed is a great resource. It's run by the NIH, and you can basically you type in Google LACTMED and then the name of whatever medication you're taking. And if they've got research on it, which they do with most medications and even some supplements, they will give you the research that's available. And it's great because sometimes it's like, hey, this is what we have. We don't have much, but this is what we have available, and you can make the decision on your own. It's not as if, someone else is telling you, oh, this is a category L2 or L3, and then you're left with the question of, well, what does that mean for me? What has happened in the past that has made this categorically questionable? So I really like that resource, and I would recommend using it anytime you have any questions along your breastfeeding journey. One thing to keep in mind, especially in the early days, so think the first month is babies suck differently on a bottle than they do on the breast. And one of the most eloquent ways that I've heard somebody describe it is that you have bottle skills and then you have breastfeeding skills. And when a bottle is not introduced, baby's just working on those breastfeeding skills and improving and improving and improving. Time and efficiency and effectiveness, all of that kind of go hand in hand, and there's just improvement. But when you introduce a bottle, sometimes what happens is that interferes with the continued development of the breastfeeding skills, because those bottle skills can just shoot right up because it's easier. It flows faster. They don't have to have that down to a science. Breastfeeding is so particular. Babies have to be in a certain position, and you have to get a good, deep, asymmetric latch. And there are all these little, positional and latch things that are very important to baby latching comfortably and well at each feed. Bottle feeding is you tip that thing upside down and it just starts dripping out. And so it's different skills, and it's definitely something to keep in mind when you use it. Now, that does not mean you should not use bottles. Sometimes there is a need when you should use bottles. For example, if you have your milk supply takes a little bit longer to come in, and or baby is just voraciously hungry and unsatisfied and unsettled, and you feel like you need to incorporate a supplement, there are lots of other ways to supplement early on, like syringe feeding, spoon feeding, cup feeding, a ton of things. But sometimes the most expeditious way, when we're talking about needing to get baby larger volumes, and or it's 4 a.m. and you've been up all night and you've been attempting to breastfeed and then pumping, and now you're at the point where you're supplementing, sometimes you just don't want to bring out that tube and syringe or something like that. Introducing a bottle can contribute to baby developing a flow preference. However, that isn't something that is not recoverable from. So weighing that with, okay, I've got the lactation support that I need in place. I'm going to introduce this bottle because this is what we need to do in this moment for our family or for this baby or whatever the case may be. Don't feel like you're irreversibly ruining your breastfeeding relationship. That's definitely something that can be navigated, but just something to keep in mind. It is easy to overfeed baby with a bottle. So one thing I'll touch on really quickly is called paced bottle feeding, and that's where I'm going to use this marker as an idea. So a lot of times in movies, we'll see, somebody holding the baby and just holding the bottle sort of upright like this. And if you do that with a newborn bottle, even the ones in the hospital with the nipples that say slow flow, turn it upside down before you start feeding baby and just watch it drip, 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 drip out. And remember, the small volumes of colostrum that you're making in those early days are for good reason. Baby is learning to suck, breathe, and swallow all in a rhythm that works for that baby and keeps it safe for them to continue to breathe while they're feeding. And so if you give them a very quickly flowing bottle sort of in this position, just drip, 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 that can be tougher for them to manage. And it can be tougher for them to realize when they're full. So babies can absolutely overeat, and follow up with your provider if you've been instructed to supplement, whether that's pumped breast milk or formula, in terms of how much they expect baby to be taking in according to the day of life. So for example, what we used to say in the hospital was in the first 24 hours, if you're doing any sort of supplementing, you would do somewhere between 2 and 5 milliliters. If you are in the second day, so 24 to 48 hours, you would do something between 5 and 15 milliliters. Third day, 15 to 30 milliliters. Fourth day, 30 to 45 milliliters. And then after that, it really is quite variable what baby will take. But knowing the signs of satiety versus the hunger cues, that's really what you should follow, regardless of the days of life. We obviously don't know what baby's transferring at the breast in those early days, and that's okay. If we're looking at the whole picture and we think baby's either getting enough or we want to just offer a little bit to see if they need more, just follow those signs of satiety. So if baby starts to, you've got that milk flowing and they start to slow down, or dribbling out the side of their mouth, or their hands are open and relaxed and their arm is maybe loose, like you can pick it up and it's just kind of loose. That's an indication that baby's feeling satisfied and not particularly hungry. An indication of hunger is going to be tight hands near the face, maybe, rooting around, looking for things to sort of latch onto. Those are all indications that baby may still be hungry. So again, things to keep in mind when you consider bottle feeding. So a couple other things of note. One, you can breastfeed in public. It's legal. It's biologically normal. You may have personal feelings, against it or something like that, and that's okay. There are nursing covers and things like that, but it's important to be able to feel comfortable feeding your baby wherever you are and wherever they need to be fed. And you can go back to work or school and continue to pump your milk and feed your baby breast milk. So just because you have to return to school or work does not mean your baby's breastfeeding journey is done. And remember too that you can breastfeed even if you smoke, vape, or take medications. I know we talked about Lactamed already. However, regarding vaping and smoking, do know that secondhand smoke and vape smoke can increase baby's risk for health problems. And the chemicals in cigarettes and vapes do pass through your human milk. However, it's still better to breastfeed than not to breastfeed. Things that you can do, first of all, obviously, try to quit. That's a good place to start. But if that's not where you are, taking your clothes off after you've had a cigarette, having cigarettes or vaping outside of the home, changing into sort of new clothes that don't have that secondhand smoke on it, not co-sleeping with baby, all of those things are ways to make it a little bit safer for baby along the way. So with regard to bottle feeding and breastfeeding, if you do end up using a bottle, so again, we commonly feed the baby like this. We just sort of hold the bottle upright, hold the baby. And what I would encourage you to think about is something called paced bottle feeding, where you take the bottle and you hold it a little bit more horizontally. So if this is the nipple, you just tip it just enough for the milk to get into. And if you did this over a trash can or a sink or something like that, you would just see, if a drop comes out, it's certainly not flowing like it is if you hold it upright like this. And even for your slow flow nipples that don't drip out when you turn it upright, this is still better because, again, it's, baby's sort of more upright. So you would prop the head higher, butt lower, have the bottle a little bit, as much horizontal as you can with just a little bit tipped forward into the nipple. And that way gravity is not helping that milk flow out in this position. Baby's having to work a little bit harder to pull that milk out of the bottle. And that is more similar to breastfeeding and can help baby transition between breast and bottle as your breastfeeding journey continues. Okay, so we're going to touch a little bit on your stay at the birthing facility, and just like you've likely read about sort of interventions impacting how you have your birth. The interventions about how you have your birth can impact not only whether you end up having a C-section or a vaginal delivery, or whether you do it the way that you want to do it or the way that ended up having to be medically done. Those things or what happens in your birth story can end up impacting breastfeeding. Now, much of that is out of our control. Some of it is within our control. So we'll sort of talk through ways to best prepare for and support moms during the birthing facility stay. A doula is a great place to start. An advocate for you while you're giving birth, while you're going through labor, someone who can help you move in and out of different positions to become more comfortable, someone who can remind you in the throes of those moments that become very difficult about your choices and what these things mean, what your original outset goals were, and why it might be good to sort of come off of those goals and transition into a different direction. Very, very great resource. And the science is proving that birth outcomes are better with them. So highly encourage you to consider looking into having a doula. Some hospitals provide them for free. There are other resources to see if you can find them. And even some insurances are beginning to cover for support, if only partially. Something that you can think through ahead of time is pain relief. Like, what types of pain relief options do you want to keep on the table? The most important thing there is just to know your options and know what your points would be to kind of transition from one choice to another. There are things you can do to decrease the discomforts of labor. So different breathing techniques, movement and walking can help, massage and relaxation as to the extent possible, heating pads, cold compresses, and support from someone you trust, whether that's a partner or a parent or a doula, or a best friend, whatever that is for you, finding someone who can be there for you in that moment is going to be very helpful. And remember to try to cope as much as possible as you can at home, because laboring out of your home just isn't as comfortable. So, on the other side of it, however you have the baby, whatever your birth story is, in its own right will be, a very emotional story, regardless of how it goes, whether it's the way you want it to go or not. And that's an important thing, which we are not really going to cover here. But once you get through that moment, you're sort of embarking on a journey of feeding this baby. And for the next few days to weeks, that is going to be the all-consuming thing. So you're at the birth facility, you've transferred into this part, you've had the baby, you're transferring into okay, baby's out, what am I doing? First thing I would recommend is just start with skin-to-skin contact. There are some really great things that come from skin-to-skin contact. One of them is that it keeps your baby warm. So immediately baby comes out of the birth canal, is often wet and is being dried down or patted down. Have them do that on your chest, skin to skin. Your chest keeps baby warm. So one of the things that can happen right after birth for babies is that it can be difficult for them to regulate their temperature. If they are skin to skin with mom, the difficulty decreases significantly, and there are better outcomes from that. Also, that golden hour right after birth is very important in terms of establishing early breastfeeding. And it can help them regulate blood sugar as well. So baby is transitioning from having food continually supplied through the umbilical cord in utero to now needing to get their nutrition on their own on the outside. And so it's expected that there would be a little bit of a blood sugar dip in that part while they're figuring it out. But the frequent on-demand feeding is what helps them through that, what helps them navigate through that process, and getting that established right from the outset, right once they come out of the birth canal is the best way to do it. They have great reflexes in place, and a lot of times you can see, if you set baby on your belly. There are these amazing videos out there about the breast crawl, which is something where, again, if you set baby on your belly or near your chest or something like that, they will eventually sort of work their way with their own reflexes and their own movements to the breast and latch on their own, even if left to their own devices. Now, of course, obviously it's easier if we're providing support with arms and hands as they're sort of moving around and wiggling and whatnot. And you can expedite it by doing that. But it's great to take advantage of those initial reflexes right out of the womb and just initiate that breastfeeding right away. Non-nutritive suck is something that's soothing to baby. So even once the colostrum has been expressed through a feed, it's still sort of calming the baby just to breastfeed. Bonding is happening in that time. The prolactin and oxytocin is starting to flow, and moms are developing that connection. Now, I'm not going to pretend that it's just like an immediate, oh my gosh, baby latches and I'm bonded. That is, again, a process, and that first step is just the beginning of it. And it can also help steady baby's breathing. So if there's some concerns about the rapidity of the breathing or something like that, then absolutely that can help. So yeah, try to feed within that golden hour, and that really encourages a great start to breastfeeding. While you're in the hospital, rooming in is recommended. So it's good for both mom and baby. You may feel the desire to sort of give baby to the nursery so that you can have some time while you've got an extra set of hands. And that's okay. However, what is recommended is if you've got baby in the room, you're going to notice those feeding cues sooner. And you're going to get practiced at knowing what's a feeding cue and what's just a little, little movement where they're going back to sleep or something like that. And you're going to be able to catch that hungry baby before they get hangry and angry for not eating. So again, having a trusted support person there with you if you have any concerns about, how tired you are or something like that with baby in the room, that can help alleviate some of that, but then you can still have baby in the room. And they get comfort from being near you, from smelling you, from hearing your voice, which they do recognize. That's all calming and sort of helps baby adjust to the outside world. Something to keep in mind is that baby's first bath, if you want to do that in the birthing facility, can be done in your room. But it's good in general to delay a bath until the baby's sort of adjusted to life outside the womb, and that can take some time. So you don't have to rush that. It's not necessary right away by any means. So now you're in the period of, okay, we're feeding this baby for every feed, and we need to be, obviously super responsible and taking care of this new life. The most important thing you can keep in mind to look for is the feeding cues, and follow your baby's lead. So on-demand feeding, when you see hunger cues, feed baby. And it can feel like a lot. It can feel overwhelming because that can happen frequently. Because, when we go through these hunger cues and these signs that your baby's ready to eat, you will see, it's a lot of any movement basically. So for example, if the eyes flutter or if they begin to wake from sleep, or if you're holding baby and they start to sort of nuzzle into you, and this happens even when dad's holding baby, is they start to root. So think, okay, they're sleeping, and then they turn towards you, and then they just start opening that mouth and sort of bobbing around. When they bring their hands to the mouth, which is something they do in utero too, but it's an indication, hey, I want to suck on something I want to eat. When they're sucking on their tongue, or making sort of mouth noises, tight fists, often like when they're sort of lifted up either to the face or the chest or something like that. And if it's gotten to the point where baby's crying because they're hungry, that is a late sign of hunger. That's a late hunger cue. And so you don't want to get to that point. Now, in the first 24 hours, that can happen sometimes, whether it's someone comes in right when you're about to feed baby and they've got to do a test or something like that. Try obviously to advocate for baby and staying on that feeding schedule, which is at least every 2 to 3 hours. But on demand. And if you can't, or if you get off schedule, or if baby just gets hangry before that mark, it's okay. Just try to catch baby before they get to that late stage cue. Alternatively, some signs that baby is full and no longer hungry because they had a good feed is the sucking slows down. So you might get big pulls, big strong pulls at the breast while baby's latched initially when they're hungry, sort of like, just, wow, this baby's really going to town. And then you start to get into what I call flutter suck, which is just a lighter suck, or it's a big strong pull and then they stop. Now, stopping for a few seconds to breathe, to catch their breath, that kind of thing is fine. And if they get started again on their own, they could very well still be hungry. And that's just part of that learning how to suck, breathe, and swallow in a rhythm that works for them. However, if it slows down and they don't really get started again, or if you tickle and try to wake baby up, top of the head, inside the palm, on the back, on the feet, those types of things, and baby's really not waking up and the feeding's really slowed down, that's a good sign. Sometimes babies come off and turn their face away. That's always a good indication. Or if the hands go from sort of like hangry, tight hands near the face to open fingers, and then the hands start to sort of come away from the body, or they're just loose. Sometimes we don't see that until we have higher milk volumes, but even sometimes with colostrum we do. And sometimes a cue can be like if they've fallen asleep, that can be a good indication that the feeding's done. But not always. So do try to wake first. If you notice baby's fallen asleep, try to wake baby to get going again. And if that doesn't work, then maybe the feeding has ended. A note on pacifiers. The reason why pacifiers are commonly encouraged not to be used in the first few days is because they can hide baby's hunger cues. So the goal is to get breastfeeding really well established and then introduce the pacifier. And so what does that mean? It means you know when your baby's hungry, or you feel confident that you know when your baby's hungry. Now, different professionals will advise different things. Your speech language pathologist will probably tell you never use a pacifier. Your pediatrician will probably tell you pacifiers decrease the risk of SIDS, which the research proves that they do. And that's near the 1 month mark. So it's not as if you're like missing a window of opportunity by not doing it in the early days. However, ultimately at the end of the day, what you decide to do about a pacifier is really up to baby. Some babies take them and some don't. But the key to remember in the early days is not to let it hide babies' hunger cues. You don't want to miss those early signs of hunger. Otherwise, you're getting to that late stage of hunger and blood sugar has really dipped at that point, and it's harder to latch a crying baby and all that kind of stuff. Do remember, here's some good little like fruit shapes to give you an idea of what baby's belly size is based on the day. In day 1, the size of the belly is a grape, or the tummy is a grape. Day 3, it's the size of a cherry tomato. Day 7, a strawberry, and at 1 month, a lime. So as you can see, the shape of the stomach really does change even immediately, right? From the size of a grape to a cherry tomato. I mean, there's a difference there. And so when we talk about, in the first day, these small volumes of supplements, if that's something that you end up having to do, or if you're worried you don't have enough, I'm seeing drops when I express, that is normal. Babies' bellies are small and the capacity is low. So don't feel like that's abnormal. The size of the belly of the tummy is small. So the recommendation by a multitude of resources, from the American Academy of Pediatrics to the World Health Organization and others, is early and exclusive breastfeeding through the first 6 months. So the goal is to get baby latched within the first hour. Of course, there are circumstances where that doesn't happen, so just as early as possible. And then no other liquids or solids while breastfeeding baby through those first 6 months. Keep in mind, babies don't need water. Breast milk is 87% water, so there's a ton of water content in it, and it is everything baby needs. Breast milk is everything baby needs in those first 6 months. So definitely that's the recommendation. And then after that, incorporating solids and continuing to breastfeed, as long as is mutually desired by mom and baby. Some benefits that mom or the lactating parent will experience from breastfeeding is the convenience. So if you pump instead, that can be difficult because obviously you have to wash the pump parts, or you have to assemble all the pieces, or you have to make sure you pack the things when you go out of the house or something like that. The convenience of breastfeeding is like, oh, I didn't know you were going to be hungry right now, and we're in the middle of a park playing with your older brother or whatever the case might be, and you just latch baby and feed him. There's, obviously the fiscal aspect of having to buy other things to alternatively feed baby. In other words, if it's not breastfeeding, you'll have to buy formula, or if you plan again on exclusively pumping, sometimes the pumping supplies, I mean, that's just a rabbit hole in and of itself, the number of things that you can buy to make that either more comfortable or the fit just right or more portable or that kind of thing. Lactation is linked with a lower risk of disease for breast and ovarian cancers, as well as type 2 diabetes. Lactating does help your uterus contract and slow the bleeding after birth. So that's another sort of benefit of it. And you can use it as, I don't recommend this, but you can use it as a method of contraception. It is not, you don't know when your menstrual cycle will return. So it is not, the reason why I don't recommend it is because it's not something you can rely on with statistical, it's not 100% reliable. That being said, for some people, if as long as you're breastfeeding overnight and on demand and every 3 hours and all that, you're not going to get pregnant again, and your period may not return for quite some time. But again, I wouldn't rely on that. Certainly, if you're not looking to have other children, it's definitely not 100% by any means. And for baby, the benefits are that obviously the colostrum is the ideal first food for baby. The antibodies that are provided help fight off diseases, and it is easier to digest than formula. So think less gas, less cramping, less potential for overfeeding, that type of thing. So some conditions that are less common in babies who are breastfed are ear infections, diarrhea, pneumonia, diabetes, SIDS, stomach infections, overweight and obesity, childhood cancers, heart disease. Keep that in mind that those conditions are less common in babies who are breastfed, per the current research that we have available today. But at a certain age, that does, sort of even out across the ages. So just of note. Now, one thing also to keep in mind is that there's this thing out on the market called follow-up or weaning formula marketed for babies who are 6 months or older. Not needed. Your typical formula, if you need formula, is all you need. You don't need to do like a weaning one or something like that. They're usually higher in sugar, costly, not something that you need by any means, and certainly not after a year. So for those of you who would want to do what's called the term extended breastfeeding or continued breastfeeding beyond 6 months, you can begin offering other foods to your baby after a full breastfeed when your baby is 6 months old. And, it is recommended that you continue to breastfeed for 2 years and beyond as long as you and your baby desire. Continued breastfeeding is beneficial for your baby's growth and development and for protection from diseases for both of you. So getting into some of the fun stuff here, position and latch. I will try to provide some links in the notes to sort of point you to some videos and resources to see actual images of some of these positions. But we're going to talk about a couple different positions that can work to latch baby. The laid back breastfeeding position or leaning back is great. It's wonderful for, we talked early on about breast anomalies or nipple anomalies or oral anomalies for babies like tongue ties and that kind of thing. In those cases, laid back can be even more helpful. And we talked earlier also about putting baby sort of on your belly or your chest after you've given birth. You're in a more reclined position at that point. That is that laid back position, and getting baby latched in that position is it gives them an opportunity to capitalize on the reflexes that they've been born with. So baby's belly completely up against your body, hands out. We call this sort of hugging the breast. So one hand on either side of the breast. And, then that gives them opportunity to sort of use their feet and try to find their way and, move their head to find the breast and latch. So laid back lends itself well to really using all of those reflexes that baby was born with. And so what does that mean for you? How laid back are you? I mean, you could be all the way, and you could just be laying on your back if you wanted to. You could be at a 45-degree angle. You could be, it's not an exact science about how laid back you are, but the idea is that baby is on top of you. And we'll use some of my handy dandy supplies here. I bought this knit boob at a postpartum support training that I went to, and I love it. It's great. So, if you're sitting up, breast is like this. If you're laid back, breast, the nipple is pointed in this direction. But if your breast is like this, baby's next to it or under it to latch, right? And so next to it or under it to latch. And what we really want to see in the laid back position is mom's laid back, baby's latched, and on top of the breast, like this. And One of the things that helps with is if baby has a tongue tie, gravity is helping baby fall deeper onto the breast to get that deep latch. Now, you might find as the mother who's laying back that, okay, now baby's falling onto it and sort of smushing into the breast. So what you do is you compress the breast up like this, and we call this sandwiching the breast. And so if this was, on my chest, this is a U-shape compression, and then this is a C-shape compression, okay? And any version between the two is going to give you sort of what you need. So if baby's sitting across the front of your body, like so, then you can do the C shape because you're compressing. You want that breast compression to be happening in like sort of along the smile on baby's face or the lips. So you would compress the breast this way. Now, if baby was laying in this direction, you would compress the breast this way. So that's sort of the idea. Think of a sandwich that you're about to take a bite of, right? That's what we want is baby to have the opportunity to take a big like latch onto that breast. And so if I'm compressing the breast this way or thinking of it this angle and baby's trying to latch this way, they don't really have a lot to grab onto. But if you line it up with their lips, again, compress the breast this way, they get a good deep latch that way. And so in that laid back position, you may find that you have to compress your breast in line with baby's mouth to help baby to latch that way. And or support baby's body maybe with like the side of your arm or a pillow under your arm while you're sort of compressing your breast this way, something like that. And it can feel, laid back breastfeeding can feel very ungraceful. When you first do it, you can kind of feel like, what am I doing? I feel like breastfeeding should come easier than this. But keep trying it, keep exploring it, keep playing with it, because it really does sort of trigger all those reflexes that baby was born with and can make for a very easy experience. The other thing is, in the other positions we'll talk about, a lot of times what we see is moms working to get baby latched, leaning over. And then by the end of it, okay, you've got baby latched in this position, you don't want to move, but your shoulders are hunched, your neck is sore, your back is sore, all those types of things. And that makes for an uncomfortable breastfeed, especially when you're doing it for 30 minutes, 8 to 12 times a day. So highly recommend the laid back breastfeeding position, particularly in the early days, and especially if we have any nipple or oral anomalies. Some other positions we can talk about are the cross cradle hold, the football hold, the cradle hold, and side lying. So for the cross cradle hold, this is the second most common position that I would recommend for newborns. So laid back breastfeeding is my preference. Cross cradle hold, sort of next in line. What we typically see, and which we'll talk about in more detail, I'm going to try to, here we go, get a little. Okay, so what we typically see in the movies is the cradle hold, which is where you're just sort of holding baby like this, in front of your breast, and you got them in your arms and they're latched and it's easy. That is awesome if it is. But even for moms who have breastfed before, you will commonly hear that that is not the newborn position. Newborns have a tendency to let their heads flop all around in every direction and or, kind of like this little lamb is point their head in a different direction than you actually need it to be going. They'll be looking off in this direction when the breast is over here. So the benefit that cross cradle hold gives you is the ability to have a little bit more control over their head. So you sort of grab behind the ears and you can feel that place behind your ears, that hard bone, that's sort of where you're grabbing behind the ears. And you do that with this sort of C shape behind the ears. This gives you, and your palm ends up between baby's shoulder blades on the back. And that gives you a lot of control and a lot of support to baby's neck. And it gives you the ability to help aim baby's head. And what you don't want to do is put your hand on the back of the head or on the top of the head or anything like that. When you do something here, baby's going to push against that and away from the breast. So you really just want to go at the bottom of the back of the ears to sort of provide that support to baby's head and be able to point baby in the direction that you want to. So you're reaching across your body to come behind the ears of baby and to the opposite breast, and then you're using the hand on the same side of your breast to do that breast compression that we were talking about to get baby to latch. So if this is baby and breast, you are going to reach under and do sort of a U shape in this direction and bring baby on like this. So now, what do you do? You may need pillows underneath your arms, underneath baby, all those types of things. Put pillows for support where you need it. Make yourself comfortable. And make sure that you're bringing baby to the breast, not breast to baby. When you bring breast to baby, you lean forward and you end up in a very uncomfortable position that you feel like you can't move out of because you're like, oh man, I just got the perfect latch and baby's happy and I'm just going to sit here in 7 out of 10 pain. Don't do that, because 7 out of 10 pain usually means baby's not transferring as much milk as they could be. And we'll talk more about that. But the idea is, here's your breast, bring baby to the breast, compress the breast, get baby to latch on here. We'll talk about latch in a second. So this is the cross cradle hold. Your hand is coming across your body, again, to support the back of baby's head. You've got more control of the head here. And as you can see, baby's hands are on either side of the breast. Again, we call this hugging the breast. You're compressing your breast, and you're letting baby come to the breast, leading with the chin, which I don't know if you can see on this little lamp. But it comes here and then goes up and over the nipple to latch on. And so cross cradle hold is great and second only to laid back breastfeeding, in my opinion, in the newborn days. Now, another position that our moms with bigger breasts like is football hold. And in this case, what you would do with football hold is two things, especially in a hospital bed. The pillows that they give you that sort of lay left to right like this, the rectangular pillows, turn those this way and put them behind you. And, you may need a few to bring you further forward so that you're sitting away from the back of the bed. Now, what this is going to do is allow you to tuck baby further back. So if you're laying against the back of the bed and baby's here, they're too far away from the breast to get a good latch. And that makes it painful when they do latch and difficult to sustain the position. So if you've got pillows stacked behind you, it brings you further forward. You put some pillows next to you that your arm can rest on while you're holding baby. You line up baby's nose to nipple. So in this case, we'll use the breast here. Nose to nipple. Same hold behind baby's ears, right? So this is giving you the support to baby's neck, but also the ability to sort of turn their head the way that you need to. And again, you've got your hand on your breast for compression. Now in this position, you're going to go underneath the breast into a U shape for compression so baby can latch on and get the biggest mouthful of breast tissue. And so again, line up nose to nipple, let baby come to the breast leading with the chin. One hand on either side of the breast, up and over the nipple. And then you can hold baby in this position. You may or may not need to continue to hold your breast in a compressed position. If you let go and baby has a difficult time holding on, go back into compression. Hold it there for a minute or two. Try again to come away. So again, football hold is comfortable for our bigger breasted moms. Sometimes moms even need a little bit of like a folded up blanket or something like that can go underneath the breast, in between the breast and the rib cage, to sort of hold that breast exactly where they want it, and that can be more comfortable for some. Now again, we talked about the cradle hold already, but just to sort of give you an idea, same thing, lining baby up nose to nipple. So I've already got the sort of cross cradle hold position, but it's like this. And then you find yourself kind of doing this where you don't have the dexterity that a hand does with this part of your arm, trying to get baby aimed onto that breast and then trying to figure out how to do the compression. It's just not as coordinated as it is when you're doing cross cradle hold. Now, it can become that way, and as babies become more capable and as you're able to get baby latched and baby's working with you to get latched, that cradle hold will probably be the clutch hold that you end up doing for quite some time. Side lying, not something I recommend in the early days because a lot of times babies are they're too small, or just not coordinated enough, or you can't see them latching onto your breast, something like that. But you basically lay on your side. And then, the important thing to remember again is supporting and aiming the head by holding onto those bones behind the ears and sort of supporting the head. Now, in side lying position, so if I'm on my left side here, the important thing to remember is baby still needs to lead with the chin. So a lot of times when babies are laying on their side, they're going to be in this position. So you've got to sort of extend with support on the neck, but you've got to sort of extend so that their chin is coming up this way, and they're coming to the breast with the chin leading. And that will allow them to get that deep latch. And you're still going to have to, maybe if you're on your side, you're having to reach this way, you're still going to have to provide some compression of the breast. So it's this way, then you've got to do it this way. And in doing so, allow baby to have more to grab onto. But sometimes this one takes a little bit of time until babies are capable of doing. But certainly a great tool, especially when you're trying to keep things low key at night, as long as you're not at risk for falling asleep or something like that. Doing a side lying position can be much more comfortable on your neck and your shoulders and your back and all that fun stuff. So again, some of the stuff we've already touched on, but talking about the tips for latching baby, you're going to be supporting the neck, right, by grabbing onto the bones sort of behind the ear, and not grabbing onto the back of the head or not having some of your fingers on the back of the head. They really don't like that. And it allows them more movement if you sort of just are holding onto this part. And another thing to remember, I love this one, is to remember that ear, shoulder, and hip should all be in a line. That means baby's whole body is facing the direction that it needs to get a good deep latch. And I had a coworker once who said this, and I loved it. She said, it's like, when they're young like this, newborns, they have to come to the table and really sit at the table in good form. We're old enough, it's like eating, when they come to dinner, they have to sit in good form. And, if your ear, shoulder, and hips are all in line, you're facing the table and you're ready to eat. We're old enough and or have enough distractions during dinner time where it doesn't matter if I'm eating here, I can turn this way and continue to eat. And it's the same as they get much older and further into their breastfeeding experience. They're not going to need to be in that perfect positioning every time. But in the early days, they do need that ear, shoulder, and hip all in a line. And that kind of guarantees their body alignment is in good position. One of the things that you can do is, as you're compressing the breast, you're sort of you're holding your breast and you're dragging the nipple from the nose to the upper lip and sort of off like this. And that should elicit a wide open mouth. If it doesn't, if baby just opens a little bit, don't try to cram your breast tissue into that space. We want to teach baby to open really widely after you've taken the nipple and sort of dragged it along the nose and the upper lip and elicited that wide gape, and that's when you go and you put the nipple in. Don't forget to bring baby to the breast, not breast to baby. So some things you can think about: lean back, relax, don't hunch over, that kind of thing. In any of these positions, again, which we already alluded to, is that baby's chin should hit the breast first. So with the right support behind the ears, they're really leading with the chin, and then they're going to come up and over the nipple. Very important here, make sure the nipple is deep in baby's mouth. So I've talked about this before in other podcasts, but if this is baby's mouth, the roof of the mouth is sort of sometimes deeper than we think of it. And we want that nipple to go up into the roof of the mouth. So one of the visual cues that I like to give parents is think of aiming the nipple behind the nose. So if we're doing that here, the nipple's really got to go, in sort of this, actually probably easier if I do it this way. The nipple's really got to go up this direction or be aimed in this direction to be able to reach that roof of the mouth positioning. And why we want to do that is because you can trigger a suck reflex by hitting the roof of the mouth, and baby's going to be able to hold on to that breast tissue and maintain that deep asymmetric latch for the duration of the feed. So just a couple things we've talked about already, but just reminders: breastfeed as soon as possible after birth, ideally in that first golden hour. Skin to skin is not limited to that time frame right after birth. Skin to skin often, for the days and weeks and months after birth is wonderful. Feed on demand as often as you see signs of hunger, and that should be at least every 2 to 3 hours or 8 times in a 24-hour period, but often more. Hold off on pacifiers and bottles if able until breastfeeding is well established. And anytime you feel like you need to, ask for support early and often. Just for level setting, expectations. I have worked with families and done 5 or 6 visits in the first 3 weeks. It's not abnormal by any means. So if you need a lot of help early, often, take that help. It will help you meet your breastfeeding goals and help you have the journey that you're looking to have with breastfeeding. Massage and compression all over the breast while feeding can help flow. This is great. So if baby's falling asleep, so baby's latched and on the breast, sort of doing this, you can move your thumb and then come further up in the breast and then push forward. Now this knit breast doesn't do a good job of sort of like giving you the visual cue. It glides easier down skin, but the idea is you're compressing the breast just like you would in milk expression to get a couple drops out. And you're helping baby, either if they're sucking, you're helping increase that flow. Or if they're not sucking, you're getting a couple drops going, and that's a cue to them like, oh yeah, we're at the breast. I gotta eat. Let me get going again. And so if you're here, and then you can kind of move your thumb around, you have the most milk ducts in the upper and outer portions of your breast, but you do have milk ducts inner and under as well. You just have the most sort of upper and outer areas. So as you're moving your thumb through those spaces, that's sort of the area that I would focus on. And speaking of hand expression, I will point to some resources on how to do. There are a couple different methods that are great, but it's a technique to express milk from the breast, whether it's a couple drops or whether you want to express more and either supplement baby with that or save it for later. Or if your breasts are really full and you just want to hand express a little bit to evert your nipple and get some of the tautness of your breast that can sometimes happen to decrease so that baby has more to latch onto. I mean, it's a great tool for a multitude of reasons. You can get some of like we talked about, the hand expression of the drops onto the nipple can if you then bring your nipple near baby, they smell that and it sort of entices them to eat if they're having a hard time waking up or something like that. Hand expression is also, from a research perspective, correlated with increasing your milk supply and encouraging your mature milk to come in faster. So a wonderful tool to know about and be comfortable with. In terms of supply, so talking about making and maintaining your milk, your first milk is your colostrum. It's often golden, thicker, and it comes in very small amounts, but it's exactly what baby needs. Full of protein, nutrients, great for the immune system. And over the course of the first 3 to 5 days, your milk will transition into larger amounts of mature milk. That has more water in it, which is good for hydrating baby, all those types of things, but it changes as is needed for baby. Something to keep in mind, and something that we have talked about already on the podcast, is that introducing commercial milk formula can decrease your milk supply because you're skipping a nursing session each time you use these products. And so the recommendation, sort of textbook guideline here, is if you do need to supplement for some reason, even if you are not making milk yet, bring the pump out and pump. And the reason why is because even if you get nothing, or even if you get just a couple drops, first, that's normal. And second, you're cueing your body. And in these early days, it's not necessarily about how much am I getting in terms of, does that indicate whether this is going to be successful or not? It's more about how much am I stimulating the hormones, prolactin and oxytocin and all that good stuff, to get the milk production going. And so if you use formula or supplement, I recommend pumping when you do so. Of note, moving your milk out of your breast is the number one from a research perspective, number one best way to boost your supply. Making a full supply does require that your milk is removed frequently from your breasts. If it's not removed from your body, then your body doesn't get that signal to make more milk. So once your breasts fill up, there's actually an indicator in your breasts that say, stop production, slow down, we've got a lot in here. And so you don't want to wait until your breasts get full to remove the milk, whether that's a breastfeed or a pumping session. You want to remove milk at the frequency that baby is feeding. That's ideal, but at least every 2 to 3 hours or 8 times within a 24-hour period. You can use gentle massage or hand expression or pumping to remove milk and to encourage that milk production to continue if you're separated from your baby. Obviously, in the first early days, it's often easiest to just bring baby to the breast. So looking at the big picture here, signs your baby is getting enough milk. If your baby is deeply attached and you are comfortable while feeding, that's a good sign baby's getting enough milk. Now, comfortable while feeding, that's something we've alluded to a little bit earlier and something I want to sort of foot stomp again. When you are at a 7 out of 10 pain, or you describe the latch as pinchy, right? So baby's latched on and you're at a 7 out of 10 pain, what's likely happening is that you've moved from a good deep latch where baby's got a mouthful of breast tissue to something more like this, where they're trying desperately to hold on to the nipple, but they're pinching it. And so that's like babies drinking through a straw they're biting on versus a straw that's open and the milk is flowing. So of course they're going to get less milk. So that's why your pain is important. A lot of times we as moms like to just think, I am going to push through this pain because I'm feeding my baby and this is what they need and this is part of it. And pain that indicates that pinching or, that's not sort of normal soreness, sort of going along, 2 to 3 range on the pain scale. When it moves beyond that, there's usually something we can do positionally to deepen that latch or to make that latch more asymmetric and deeper so that baby can sustain it without you being in pain. Or there's some sort of anomaly going on. And again, there are other things we can troubleshoot there as well. Another sign your baby is getting enough milk, your baby breastfeeds with steady sucking and swallowing. So even if it's sucking bursts, right? So they stop in between the bursts, very normal, but they start sucking maybe 10 to 30 sucks in a row. So if baby sucks 1, 2, 3, and then stops, and then 1, 2, 3, and then stops, I wouldn't really call those active sucking bursts. You want to see more of the, at least 10 pulls. That's okay. This is a really active sucking burst. And then the swallowing, you can actually hear if you listen. So suck, 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 swallow. And then it sounds like a k sound, like a very quiet little k sound. Some babies sound louder than others. Sometimes when you have a really strong flow, it's like they're struggling to swallow it because it's so much. But that's sort of down the line. That's not something we commonly deal with in these immediate postpartum periods. So the sucking and swallowing, and it is, again, normal for them to pause, catch their breath, and then get started again. Another sign your baby's getting enough milk is that your breasts soften during the feed. And you can notice this a lot more once you've gone into that sort of, after the 3 to 5 days where you're getting the more mature milk. So as your breasts feel firm at the start of a feed, they should feel softer at the end of a feed. Another sign your baby's getting enough, baby is content after a feed, or the number of pees and poops are consistent with the number of pees and poops we would expect on that day of life. Often what you hear is 1 pee and 1 poop per day of life. Now, I don't love that because stools are very different baby to baby. Some babies stool once a day, other babies stool every single time they feed or more. But the pees are the real indication of hydration. So on day 1, you would want to see 1 pee. On day 2, you would want to see 2 pees. On day 3, you would want to see 3 pees, on up to the 6th day. And even sometimes beyond that, maybe if you're doing 8 feeds a day, you're going to get 8 wet diapers or more. But generally speaking, if you see 6 pees, you're doing good. Baby's stool transitions as mom's milk changes as well. So when the colostrum gets in there and pushes the meconium out, it transitions from that dark sort of tarry texture and color to greenish black and easier to wipe off. And as the mature milk comes in and baby's getting bigger volumes, you're going to see sort of a pale or mustardy yellow, soft and seedy looking stool. The white seedy looking parts are the undigested pieces of fat, or partially digested bits of fat. And remember that those stool patterns are in line with only human milk. So if you've introduced formula or something like that those colors may not hold true. And the other thing, of course, that we have as a data point that baby's getting enough is weight gain. If baby's weight gain is normal and healthy according to your pediatrician or your lactation consultant or something like that, then you're going to be doing well. But to give you an idea of what they're looking for, again, going off the rough estimate that baby regains birth weight by 2 weeks, 10 to 14 days, it is very normal to see weight loss in the first few days before mom's milk comes in. And so normal, in fact, that I think I've only ever seen 2 babies in the postpartum period gain weight instead of lose it. And I have seen a lot of babies. Most of them lose weight. And the weight loss is going to look something like this. So this correlates with birth weight. And then you lose. And this plateau here is happening right before mom's milk comes in. And as the milk comes in and baby begins to transfer more, they begin to gain weight again. Now, as long as this happens without baby going underneath 10% weight loss, you're probably not going to get anybody talking to you about supplementation because that's so normal. It's very normal for babies to lose weight. But when you go beyond 10%, that's when providers tend to start talking about supplementing. Other situations where you might want to talk to your provider a little bit further about, should we be doing something different, is if baby's not able to get at least 8 feeds in a 24-hour period, or if baby's too sleepy to wake for feeds. Sometimes that can indicate jaundice or something like that. So we've got to come up with another way to get that nutrition into baby if that's the case. Again, if feeding is painful, that's another sign you should talk to someone for help. Or if your baby never seems satisfied, you feel like they're inconsolable and always wanting to feed and just it never ends. If feedings last longer than an hour. If you're in a period of engorgement where your breasts are really hard and tight and painful and you're having difficulty feeding baby, that's a time that you can reach out for help as well. Engorgement can be normal, and if the methods that you use to alleviate some of the pain, like ice or ibuprofen or something like that, do decrease the pain and you're able to continue to breastfeed, then it's not really something that you need to call your provider about. However, if it's impacting feeding, that's definitely when I would call a lactation consultant, pediatrician, OBGYN, something like that. Another time you might call is if baby's having difficulty latching or staying latched, which will, of course, affect feeds. And, just if you're not confident baby's feeding well. So those are the important things to keep in mind and when to call your provider and that kind of thing. Just to recap some of the things, let's review why we do these practices. So why do we stay healthy during pregnancy? We want to help baby grow and develop, protect baby from birth defects to the extent possible, and to help the birthing parent feel good during pregnancy. Why do we do skin to skin? It keeps baby warm and secure. It helps blood sugar stay up and breathing stabilize. It encourages bonding and breastfeeding, and it helps to sort of calm baby and transition them to the outside world. Why rooming in 24/7 at the birthing facility? Because it's easier to learn your baby's feeding cues. It's easier to bond and get to know each other. Helps baby to learn it helps you to learn to care for your baby, and it encourages milk production. Why do we feed on cue? It helps bring in good milk supply, prevents under and overfeeding, helps baby feel safe and cared for, helps baby feel content and satisfied. Why do we breastfeed? It provides antibodies to fight infections, provides the perfect nutrition, protects mothers from diseases, helps to slow postpartum bleeding, makes it easier for baby to digest their food. And why do we give only breast milk as opposed to formula? It keeps your milk supply up and it protects baby from sickness and disease. Why do we work so hard to get a good latch? It prevents nipple pain and damage, it helps baby get more milk, and it helps improve milk supply. So hopefully that covers the gist of things that you need to kind of keep in mind when you're in the hospital. There are, of course, other things to consider. Like, for example, once you've returned home with your baby, in the first few weeks, you're gonna want to focus on sort of nesting in with your family. Definitely focus on staying hydrated, getting plenty of food and rest to the extent possible. So what does plenty of fluid mean? Drink to thirst, but try to always have water available every single time you're feeding baby. This is a wonderful support person job. So if you're a support person, whether that's your partner, husband, wife, parent, friend, whatever it is, if they're looking for a job and they feel like, wow, you're doing all the feeding and the heavy lifting here, tell them to focus on feeding you so you can feed the baby. And what I mean by that is, of course, your meals, that would be great. But then when baby is breastfeeding, that's an automatic cue that you need to be drinking water or having a snack or something like that. And so that support person can set little nursing stations up throughout the house, wherever you are breastfeeding. So maybe you sometimes breastfeed on the couch, maybe you sometimes breastfeed in baby's rocker, somewhere in your room, something like that. If you always have some water accessible and some one-handed snacks accessible at those places, that's a really strong start and a really great thing for the support person to do. Build your village. Obviously, allow support from the people around you so that you can take care of yourself and your baby. Have people around you focus on the other sort of responsibilities of life, and you just focus on healing and feeding that baby. Limit visitors and phone calls to the extent that is desired for your family, and check in with yourself. How are you feeling? Are you feeling sad or worried? Are you concerned at all that you're maybe having some postpartum depression or feelings you need to talk to a healthcare provider about? Baby blues, they talk about as normal when it's for the first 2 weeks, but sometimes we know even before those 2 weeks that these thoughts that we're having are not normal. Seek help early. You don't have to wait. You don't have to wait till the 2-week mark. You don't have to wait until you go see your OB at the 6-week mark. If you feel like you may have some issues or excessive anxiety or intrusive thoughts or something like that, it's affecting your ability to sleep, or you're not eating well or anything like that, please reach out to a mental health professional or a general practitioner or OBGYN who can point you in the right direction. When you have other caregivers, either in the house or, when you're returning to work or something like that, talk to them about how you can best be supported. And even when you're returning to work, with your own supervisor, talk to your supervisor about how you can best be supported. When do you plan on returning to work? Roughly. How are you going to be supported in terms of continuing breastfeeding? By law, you should be given a space to breastfeed. And there are immense benefits to employers as well. I mean, the bottom line is there in terms of when your supervisor or when your company supports you in terms of giving you a space to breastfeed and the time to do so, the baby's going to be less sick. And that means less time for you away from work. And, there's benefit for both there when you support a mom or lactating parent returning from leave. Figure out what pump you're going to use, figure out whether they have sort of a hospital grade pump. Sometimes places have a hospital grade pump in the lactation rooms at different places, which is wonderful when they do that. If not, do you have a personal use pump? In accordance with ACA, it is law that your insurance should be providing, except in extenuating circumstances, should be providing you a pump that you can use for returning to work. So inquire about that. You can look into that prenatally and figure out how, do you need a prescription, those types of things, and get all that lined up before you're in the postpartum period and sort of dealing with recovery and all that. And when you're looking at your childcare options, look at a place that makes it easy for you to return to work with the least stress possible. And so if that means closer to you so that you can step away for feeds, or closer to you on your way to work, or someone who is supportive of breastfeeding and will be comfortable giving human milk, all of those things are factors and things you want to sort of talk through in the early days. Or rather before baby is due. Another thing you want to do is practice expressing, storing, and feeding baby your milk. And the sort of sweet spot to do this is somewhere between 4 and 6 weeks. Now, why that number? It's not like there's a light switch at the 4 week mark. There's no more bottle confusion or something like that. It really depends on how breastfeeding is going. So for example, if breastfeeding is going great at 3 weeks, or you're a third time mom and you're like, nope, I got it. I have dealt with, flow preference before, and we know what to do if it happens and all that kind of, and you're at the 2 week mark and you want to incorporate, whatever the case may be, everybody's individual circumstances are different. The reason why we typically recommend somewhere between 4 and 6 weeks is because we want breastfeeding to be really well established. And we don't want baby to develop a flow preference when the bottle is introduced. And then also sort of the upper limit being 6 weeks, because if you wait too long, and really it can be somewhere around the 8 week mark, so you may have a little bit of wiggle room, but even I've seen babies introduced bottles at the 8 week mark who then refuse it because they are committed to breastfeeding at that point. They're like, I'm not really trying to learn anything new. I like my snuggle time with my mom. I've got positive associations with this. This is how I prefer to feed. I don't want to take a bottle. And bottle refusal can be its very own stress, and it something you can still work through, but it's just you don't want to deal with that when you're returning to work. You don't want to deal with the stress of wondering whether baby's taken anything, or whether you need to leave work and go feed baby or something like that. So introducing that bottle, practicing how to pump, and then once you do introduce the bottle, try to keep the skill relevant. So I would say at least every other day, often every day, just to keep that bottle feeding skill relevant and baby comfortable doing it. Get comfortable with storage. One of the things that I like to tell parents is in terms of milk storage is the 4-5-6 rule. Now this falls within the range of what basically every resource out there has in terms of milk storage rules, but some are different than others. And the reason why I use the 4-5-6 rule is because it's easy to remember. So keeping that in mind, if you see another source that says the numbers are different and you prefer to use one of those numbers, obviously go with that. But if you're just looking for something that's easy to remember and a rough guideline, 4 hours at room temperature, 5 days in the fridge, 6 months in the freezer, unless you have a standalone freezer, in which case it's 12 months. And again, talking about the variability of those storage rules, I think one of those sources says that it's like 5 to 8 days in the fridge. So keeping that in mind, just know that there is some variability there. But again, 4-5-6, I often tell parents because it's easy to remember. Now, we've talked a little bit about how partners can be supportive of people who are breastfeeding, and it absolutely is a team effort, and this is something I've talked about a little bit on the podcast, but definitely want to go into more. One of the most important, obviously, we just talked about, the support person feeding the person who's doing the feeding of baby, right? So, feeding is like an easy one. Feeding, hydration, that kind of thing. Asking if you can help with baby. Like, okay, I'll do the diaper change before while you get ready, or I'll wash the pump parts or something like that. One of the things that is just immensely helpful and shows a big sign of support is learning about lactation. either together or separately, just being able to participate in the discussions about what baby needs, to know what baby needs, and to anticipate those things, and to help mom or the lactating parent remember in the moment, especially when it's 2 or 3 in the morning and everybody's delirious and it's like, when was the last time baby fed? And I don't know what's supposed to work here. If you've got two people sort of knowledgeable about what needs to happen with lactation, you're going to fare far better than if it's just all on the shoulders of one person. You can attend classes together, do support groups. You can do that prenatal consult together that I was mentioning through, with a lactation consultant or something like that. And then just provide support in other ways. Be the person who says, no, we can't have any visitors right now. I'm sorry. We've got to focus on baby. Or the only visitor who can come is grandma. Whatever the desire is of the lactating parent, be the person who provides that support and that either barrier or layer of protection that the lactating parent may be looking for. Chores, obviously. A healing parent or a lactating parent who's got their hands full breastfeeding baby all the time is not going to be the one who's up doing the dishes and cooking dinner and taking the trash out and all that kind of stuff right off the bat. And just see how they're doing. There's a lot in the way of hormonal changes that happens postpartum that a partner can often be the first line of defense in terms of spotting these things, even when the birth parent is not aware of it themselves. So be that sort of partner checking in, asking how they're doing and in what ways you can show up for them. And then comfort, right in the moment of breastfeeding. I mean, the partner who says, I feel like I can't participate here, is a partner who's not asking, like, is your left arm comfortable? Do you want another pillow? Which, ask that question. I mean, it makes such a difference. It sounds like such a little silly thing, but again, we often sort of hold these hunched over positions or whatever because we're like, okay, baby's latched and we're going to keep it heavy. But if your partner swoops in and is like, why don't you rest your arm on this pillow here and lean into that a little bit? Is that more comfortable? I mean, that can just make a world of difference. Again, snacks and water, and taking the opportunity to try to connect with baby when you have the moments with them between the feeds, diaper changes, getting them to sleep, those types of things, can be very reassuring to the lactating parent that they're not the only one attempting to bond with baby in this time. Obviously, if you're doing baths, that's something that you can do. The person who's not lactating can absolutely still do skin to skin, and it is still great for baby. You can wear the baby, especially if you want to give mom the opportunity to just have two hands or take a shower or whatever, but baby's having a hard time laying down or needs to be soothed or something like that. Baby wearing is great for that. Read books and just learn techniques to sort of calm baby or massage baby or soothe baby in some ways. Instances where you want to talk to a healthcare provider, if you're not sure you have enough milk, we've talked about potential instances where we don't know if baby's getting enough. If you're not sure you have enough milk, that's a great time to talk to one of your healthcare providers. If you're concerned baby's still hungry after breastfeeding, if baby's having trouble with nursing, if it's painful, or if you feel like, for some reason I feel like formula would make this easier. Before you do it, just talk to a healthcare professional. I mean, maybe the root cause of why giving formula would make this easier is not at all to do with your supply and can be resolved through some other means, and then you don't have to give the formula. Or if you really want to do it and you want to talk to somebody about how to safely do it, great time to talk to your provider for that. Engorgement. So if your breasts are really hard and painful and tender and that kind of thing, it's another good time to talk to your provider. If baby's crying a lot and you're having difficulty soothing baby, so babies cry, right? But then there's a range of normal, and there is sort of on the far end when baby just seems inconsolable, no matter what you do. Or if baby wakes up a lot at night. Now, night waking is very normal. for newborns, because a lot of times they're sort of on the reverse cycle, so waking more at night than they are during the day. And I would say not a lot of times, the great majority of the time. However, if that continues for some time, then I would say that's when you would want to say, okay, are we getting enough? Is my supply lower at night? What's sort of the root cause of why baby continues to do this? Or is there something going on with our schedule during the day that's continuing to perpetuate this I'm awake at night thing? And is there something we can be doing differently? So those are all things you can talk to your provider about. And just, anything else that comes up. I mean, I get questions about burping. Do I need to burp, baby? Very normal question, very common question. And the answer is sometimes. Breastfed babies have an easier time digesting milk than they do formula. And so sometimes they don't need to be burped. And so maybe you try for a couple minutes and nothing comes and you wonder, do I keep trying? Or baby fell asleep at the breast. Do I wake them up and burp them, or do I just put them to sleep? And it depends. I mean, for spittier babies, I would definitely recommend trying to do it after each feed, even if you keep them in sort of a on you position, still trying to preserve the fact that they're sleeping. And I wouldn't really try to work out a burp much longer than 5 minutes or something like that. Maybe a two minutes ish. But those are the types of things that come up that you wonder about that might keep you up in the middle of the night, that are just worth asking one of your providers about their opinion on, so that you can get a little peace of mind and a little more sleep. There are lots of resources for support, of which I will include, send you the references for this information. And I hope that this was helpful and a good starting point for our moms who are expecting, or our birthing parents who are expecting. And I am happy to help in any way in terms of sharing information with you. If you're not local to me, or if you would like an appointment or something like that, please get in touch. Again, my website is locolactation.com, and I do have some resources and information on there. But you can also email us at the podcast email, which is themilkproductionpodcast@gmail.com. I would love to take your questions and chat more about them, sort of in the format on the podcast, or try to directly respond to anything I can, and or provide you with specific resources in your area as available. So I hope this was interesting, and like I said, if you have any questions, please follow up. Otherwise, we will see you next week when my handsome co-host returns and is able to join us for another episode. Take care. Have a good one.